3 out of 4 GPs lack formal training in how to care for the ageing population. In this episode, Dr. Chris Bollen busts myths about ageing, giving you tips on how to age well, what to look for in medical care. Dr. Bollen is a GP and director of Bollen Health, specialising in supporting primary healthcare professionals to deliver effective care. He has held key roles with the AMA, RACGP and the Australian Commission on Safety and Quality in Healthcare. A passionate advocate for healthy ageing, Dr. Bollen has educated professionals nationwide on frailty, dementia, and community care for older adults. Welcome, Chris, to the first ever The 50 Up Club podcast episode. I'm really excited to have you here today. And even if we might have, my family watching for the first one, but you got to start somewhere. So anyway, I think what you have to say is really important. I'm so glad that you are here today. So Chris, in a nutshell, what is your mission?
Well, one of the things, and knowing that if your family is watching, and if some of them are over 50,
Yeah.
then my mission is to actually help give them the best experience of their healthy aging life. It's a really important element, and it's forgotten in by so many people. Everyone thinks that aging is that thing that happens at the other end of life, that those people that are 80 plus, that must be about aging. But our aging starts at around about mid 40s. And so we need to be thinking very carefully about it at a much earlier age. And for most people who are in their mid 40s, they don't want to think about this getting old business. And so one of our challenges is to actually get it in everyone's conscious thought that the activities that they do in their mid 40s has a huge impact on their later life. And as more and more people are going to be living to 100 than ever before, and as I say to many of my patients, as a GP, I still work 2 days a week clinically, whether you like it or not, you might end up being 100. And some of them are aghast that they might live that long. And unfortunately, or fortunately, it happens. And some of them aren't taking care of themselves. And so their experience of aging is not going to be great, even though they might be living a longer time. And this is one of the key parts that we've got to discuss is that, in our 40s, it's so really that 45 to 65, that 20-year time is the time we must most think about investment in our own healthcare, in our own wellness, well-being, and our muscle health, because it's that time which will then impact later on. And there are some really, really interesting graphs that then show what we call lifespan and health span. And so lifespan is when we are living longer, but it doesn't mean we are living any better. And we often have more long-term conditions such as frailty and a whole raft of other things, which mean we have very poor quality of life in our later years, where health span is actually living longer and we have less years of illness and disability at the end. And so all the research now says if we invest in 45 to 65-year-olds and say, right, let's look at your diet, fitness, your smoking, alcohol, all of those everyday activities that people often think, oh yeah, well, Dr. Chris is just telling me again, it's a broken record, but it's actually, no, that's going to impact your aging experience. And most people don't think about it that way. And most doctors aren't going to think about it that way. They're more thinking about it's going to link to your blood pressure, your diabetes, your heart disease. And that matters, absolutely. But sometimes, and when I talk to people, and I'll just talk about people, not just patients, but people, because that's what we are. People are far more interested in living a good, happy, well life and functioning than they are about their blood pressure number or their cholesterol number or their blood sugar number, which doctors are very focused on. And so going back to my mission is to actually talk to people about how they can improve their level of function, doing the stuff they love, and so when I look at it this way, what are the things as humans we want to, live? We want to work, play, and love. Those simple little things as humans are how do we improve our ability to function at that level? And that's part of my mission, is getting people to think about the choices they make that then impact those factors in their lives.
Mm, great. So, why are you doing this? So you were a GP. Why did you get into this?
Well, it's an interesting sort of discussion about the why. So if I look at my background, yes, I trained as a doctor. My father was a family doctor before me, and he was involved in the mid 70s community health programs that were in this country were innovated by the Whitlam government at the time, brought community health to the Australian population, where in the past it was just a medical system. The Whitlam government really thought about things differently, about how health was not just about medicine, health related to community. And underpinning that was you needed a diversity of supports in order to help communities be well for the future. So he got into that as a kid growing up. Well, I guess, maybe was I brainwashed? Was I indoctrinated? My first job was age 14 in a community health centre, answering the phones, putting together the records, meeting all the diverse people, the toy library librarian, the psychologists, the community nurses, the dietitians, the social workers that actually made up the team working with the medical practice. So very different from the majority of medical centres that we see around the place these days. So in many ways, I grew up with that, thinking about holistic person care. When I then trained, I thought, oh, yeah, I'd like to be a GP because I couldn't wait to get out of hospitals. They were, all about acute care and no continuity, where I'm about relationships and how do we actually do a good job from a long-term continuous relationship. And that's the sort of thing that matters to me, because I still have people that actually have known me as a small boy when I used to go and do home visits with my father as a GP, and I've known them, from that practice all the way through. So I've got quite a few 90-year-olds that are still coming to see me that can recount what life was life back then. And so my aim has been to keep them well and challenge them to think differently about their own healthcare and what they could be doing. And of course, that's the big struggle we have. People are often not interested in doing things for their own health. It's about, can I take another pill, doc? As opposed to Dr. Chris, the broken record that says, well, Mrs. Smith, it's we've got to actually build your muscle. We've got to actually get the protein up. We've got to actually reduce some of the medications you're taking, because I don't think they're actually doing you as much good as they once were. There is harm. And things like, your kidneys aren't working as well, which naturally happens after the age of 65. Things start going backwards with many parts of our organs. So we've got to look after ourselves, and this investment in self at an early age is a critical part. So going back to the mission, trying to actually get people to think about change themselves is a pretty tricky area, and it's much easier to give you a pill.
You spoke about being holistic in your practice, and you do train other GPs. Do you think that cost is an issue when it comes? Do you think it's education or cost, as in time spent with the patient? Because I find that some GPs are 10 minutes in and you're out and it's on to the next patient. What do you think is the issue here? Why are GPs not looking at the patient holistically?
Well, I think there's probably a number of different reasons. One could be that the pressure, the demand, there aren't enough doctors around for the population needs. So essentially, we've got way less people wanting to be GPs these days. And that part of that's the financial side, is you get paid a lot more to be a specialist in cardiology or gastroenterology. As a specialist GP, which is my training, that's way down the bottom of the income scale. So young doctors are trying to actually go, well, do I pay my HECS debt, my mortgage, and is that all I get as a GP? Maybe I'll choose something different. So there's no doubt that the financial pressures are contributing to why young people don't want to be GPs. So coming back then to, right, we've got more people in our population, and we've got more people aging. So as people, especially after the age of 65, take up a lot more appointments in your book, we haven't, our system of healthcare has not recognised that. And so it's harder to get an appointment, or if we are going to have an appointment, we've got to cram a lot more people into a day than ever before. And so you've got that as a pressure demand, but then the other demand is Medicare. Medicare is essentially saying, we will pay you really well if you see people between 6 and 10 minutes. And the way that the Medicare system works, you get paid the same for 6 minutes as you do for 19 minutes. And so reality is that that's a pretty silly way of funding things, that the longer you spend, the less you get paid. So there's no incentive for people to spend time with you. So Medicare itself has actually created this need to actually, I call it the hamster on a wheel syndrome, where people are just flying through their day doing stuff rather than going, how can I actually solve this person's real problem? How can I actually really be an anchor for this person's life and think through and work through all the little dilemmas? Now, we look at the mental health, the physical health, all of the things that need to be done in a day. So I've got to think through, right? You come and see me, I've got to look at what's on your list, because you're going to have a number of things if you come to see the doctor. What's on my list? What proactive things do I need to be thinking about? And then there's the unsaid things, like what's your mental health really like? Because most people don't come along saying, oh, by the way, doc, I'm depressed or anxious, or they come along with lots of other complaints. And so you've got to try and sort this out. So that's why things get missed. If you're only funded to do stuff in the 6 to 10 minute mark, and that's why a lot of Australians are not getting good healthcare, because there's too much focus on the throughput. And unfortunately, November the 1st, with the increased incentive to bulk bill more people in Australia, there is going to be more free healthcare. Free healthcare does not equate to better healthcare. So it's going to increase a demand on an already stressed general practice system. So that's what worries me with the changes that are due in under 3.5 weeks' time.
Can you explain a bit more about that? What exactly is the incentive?
So if I just wind it back a fraction. So currently a Medicare rebate, which is the payment that your insurance system, the government insurance system called Medicare, pays for your visit, or pays for part of your visit. So they pay roughly around about $40 for that between 6 minutes and 19 minutes. Okay. So if you're a healthcare card holder or a pensioner, currently the federal government has incentivized a GP to accept the Medicare rebate only and not require the person to pay any money. So the gap, which is the way people have called it. So people on healthcare cards are then, if I see someone on a healthcare card, I'm incentivized with what's called a triple bulk billing incentive. So that's essentially a $20 payment from the federal government to bulk bill that person. And so bulk billing means that the rebate of $40 and I get $20 extra to actually see that person for that 6 to 19 minutes. So that's what bulk billing a healthcare card person is. But if a person does not have a healthcare card, then there are two options for a GP. They either say, right, Nancy, this is going to be a $90 visit to the doctor, and Medicare will pay $40 back into your bank account once you've seen the doctor. So there's a gap of $50. Yep. So that's pretty typical sort of gap these days, anywhere between 80. I think it's about $40 to $60 could be the gap, depending on who you go and see. So if I choose to bulk bill you as a patient who does not have a healthcare card or a pension, then I will only get $40. And so I'm paid more to see the pensioner or the person on a healthcare card. And I'm obviously taking a big cut in that fee compared to what it would be if you were a full fee paying person. So does that help you understand it?
Yeah.
Then on November the 1st, if the practice I work in chooses to bulk bill everyone, what will happen is someone who does not have a healthcare card, the incentive from the government is to pay an extra $20 to the doctor to actually bulk bill you. So it'll still be about $60 as opposed to the $80 to $90 that the practice may already be asking you to pay if you go and see the doctor. So you can still see that November the 1st, there will be the GPs will be taking another pay cut if they choose to bulk bill everyone.
So why would they choose to bulk bill? Why would some choose to bulk bill? Is it maybe the area they're in? Maybe it's a low socioeconomic area, or what? Are there other reasons?
Well, the number one, yes, that's right. If there's a lot of in a mortgage belt, so often on the outskirts of all cities where there's lots of young families with big mortgages, and big mortgages are everywhere now, people are struggling to pay. And so if you're in a practice that essentially has a lot of people that struggle to pay the bill, then bulk billing does make it easier to actually say, right, well, that's fine. But what in return, it means I'm only going to give you a short period of time. So that, essentially that 10-minute visit to actually get things done. So that, and if there is a longer consult Medicare payment, but the actual amount that you get paid is way less per 6 or 10 minutes than it is if you actually are seeing a person for their standard consultation. So it's a very confusing system. The way it's been set up from what you get paid per minutes. Some industries that every 6-minute increment of time is paid the same, but in general practice it's not. So the longer you spend with people, the less you're being paid. So the incentive to actually do really good work, because many people have complex issues where you need to spend time listening, examining people, checking things out, working through their medication list, working through their other health issues, working through their mental health issues. This takes time if you're going to do it properly. And so this is where our Medicare system is no longer fit for purpose, as we've got more and more people that are complex and the GP needs to do a lot more. Way back, so if we go back to 30 years ago, when I first graduated after med school and was training, essentially the majority of people we're seeing were younger, fitter people, families, kids that had pretty straightforward, simple issues: sore ear, sore throat, fever, need a sick certificate doc, had a sore toe, that sort of thing. If a person had diabetes, they were sent to the hospital, outpatients, or they had specialists called general physicians, who were people that saw the more complicated medical issues. So GPs would often refer all of their people with long-term health conditions to general physicians. Now, general physicians hardly even exist now, because we've now got super specialists. We've got the cardiologists and endocrinologists and a whole lot of other specialists, and the GPs are now having to take on all that general physician work that they used to refer to the specialists for. So that's really been a big change, and the number of people that we need to see with diabetes, so roughly 25% of our population over 65 has diabetes. That's a lot. And so all of those people need regular blood tests, regular review of their medication, regular review of their feet, their eyes. There's a whole raft of things that in a cycle of care for a person with a long-term condition. And so there's an expectation that the GP and the nurse in a practice will be doing all that. And yet people coming to see us, they don't have a list of what do I need to do to keep myself well. which is what I think if we're going to actually do this really well for the future, every person needs their own checklist. So when we come back to the dilemmas of how to provide the right care for the right price, we need a lot more education of our community to help out, but that's not really happening.
You said that everyone needs their own list. How can we encourage our viewers who are heading into their 50s and up to be self-managing their health, and what does it entail? What kind of questions should they be asking their GP?
Okay, so one of the things I'll step back a fraction and say, right, so because there's so many different situations, but let's just think about our new friend AI, so Chat GPT or a whole raft of other things. So what someone could do is could say, right, I'm a 55-year-old male, and what are the evidence-based health checks I should be having at my age? What else do I need to do to keep myself well? You could ask ChatGPT this or whichever other AI engine. I personally use Perplexity, but so long as it's referenced, and you can ask for references when you actually put that into your ChatGPT engine. But if you ask that sort of question, you can come up with a checklist. It will create a checklist for you. And so I think that's really when we think about not enough doctors, not enough appointments, how do we use people's time better? And I think this is a really key part here. Then as a community, we should be much more thinking about our own future, our own healthcare, and using AI can help understand that better. Now, why I'd suggest create my checklist and using questions that say, what's the evidence for keeping me well at certain ages, and create that checklist, is because if you go and Google that, you come to in many wormholes, and you go into weird non-evidence-based places. So when we think about the evidence for good care and prevention, you don't want people taking vitamin and sort of vitamin by the trolley load, because there's no evidence for vitamins simply to keep you well. We've got to do stuff ourselves, like build our muscle, improve our protein intake, reduce the amount of carbs we have, make sure that we've got the right amount of fruit and veg every day. These are the everyday things that we need to be doing, and reduce the amount of sugar in our soft drinks, reduce smoking, reduce alcohol. All of these things are what it takes to keep ourselves well. But as humans, we're very good at being driven by gratification, because instant gratification often means we forget about the future.
But I hear that GPs are taught one kind of subject around nutrition in medical school. Is that correct? So they're
Well,
not really.
depends on which medical school you go to. Some of them you may not get any.
So if they're not equipped, who's giving that advice? Are they having to see a dietitian or exercise physiologist? Like where are
Well,
they getting this advice
I'll put it this way, that medical school, you come out as an undifferentiated clinician. So then you go and do your internship, then you do a couple of years in the hospital, and then you choose to do your GP training. So, it's a long way from medical school by the time you're doing your GP training. So a lot of it you pick up on the job. Within your actual exams, you've got a training program to help you get through your exams. But a lot of that is about your acute care. So acute care is when people are sick, and we have a sickness-based health system. Even though it's called a health system, it's sickness-based. So we are trained to treat illness as opposed to improve wellness. And so that's one of the dilemmas about our healthcare system. So we need more integration with all of the exercise physiologists, the dietitians, and psychology. So when we think about how to actually do this holistically, we need lots of people, but the country can't afford that. Individuals can't afford that currently, based on the Medicare system. And so you've got to have a diagnosed mental illness to actually go and see a psychologist. So with using Medicare, you can go and see a psychologist to actually, under your private health insurance, you don't need to have a diagnosis, you don't need a referral, but under Medicare, you do. To go and see a dietitian under Medicare, you need to have a long-term health condition that exists already. You can't go there just simply, I'd like to have a chat about my diet because I'm not sure whether it's a healthy diet or not. That's the way that Medicare only funds people once they've got something. So they're in straight away. We've got dilemmas.
Okay, so if you had a magic wand, what would you change to fix things?
Okay. Well, I think one of the things that we need to have is practices that have a whole raft of different health professionals within them. That would be helpful because then we'd actually be working, shoulder to shoulder with people that go, okay, so Nancy, you're a dietitian. What's your role with this person that I'm seeing? We could have case conferencing. We could actually have much better discussions, maybe which would have a weekly catch up with a team to review what's going on. And so the funding of that is actually going back to the magic wand, is having block funding to actually be able to, and block funding is different to funding by Medicare, which is based on every time I see someone I get funded, where block funding is a block of money paid to a practice to to do certain activities, but no one's counting how many you must do to get a certain fee. And so it's in many parts of the world, the system of payment for primary care is often a combination of block funding makes up a third of the payment. The fee for service, which is what our current Medicare system is, makes up a third of the payment. And then we have another third of the payment is based on you're enrolled at the practice and there's an enrollment fee paid per year to the practice to keep you well. I'm accountable for your care. So those sort of models where you have different streams of funding coming in, and then you can make a decision, right? As a practice, I've got this amount, which is a block fund. How will I spend that? Who will I employ? How will we use that to actually, for our time, where we can actually sit at a table together and talk about, what the dietitian does, or who can we refer to within our practice, where currently that time is not paid. The time as a GP is paid only if I'm seeing patients. Where block funding says, right, you can actually use this funding to be more innovative, to actually work out, well, how can we keep this population well? If we've got, and you may have heard of something called My Medicare, where people are registering for My Medicare, where they say, right, Dr. Chris is my doctor. I'm registered with Dr. Chris. So now Medicare understands that. This has been around since about July 2023, I think it started. The clarity of the benefits are not there yet, but what will happen eventually when enough people are actually enrolled with the My Medicare program, then it'll be quite clear. This is the group of people that I'm accountable for, and the government will say, right, Dr. Chris, you're accountable for this group of people. We'll start funding you to actually keep them well. So that's where I think this will head in the future. Now, that's not written down anywhere, but we look at something called the 10-year primary healthcare plan, which we're in the third year of, that particular plan. It talks about new models of how to actually keep people well, reduce them getting long-term illnesses, and keeping them out of hospital. So we've got to actually do it differently to our current hamster wheel Medicare system.
You've recently visited, was it Singapore, did you say? What did you like about their health system?
Well, there was it's like there's no perfect health system. The things that I really thought were good were watching and seeing in action the national approach to healthy aging. And it's really interesting when you compare governments. So we've got a government that's actually putting all its money at the aged care package and residential aged care end of the spectrum, where the Singaporean government's worked out that, that's very expensive. And if we're going to make a bigger difference to people's quality of life, let's invest much earlier and not wait for the nursing home end of the spectrum. And so they've actually got this, they've got set up active aging centres. There's about 35 so far in Singapore. Their aim is to have 200 of them. And Singapore has a population of 6 million people. So that's a pretty good ratio. And their aim is really to focus on people that are 55 plus. 80% of Singaporeans live in high-rise apartments. So again, from a geography perspective, it's much easier to put these active aging centres at the base of a high-rise apartment. And people come because lots of people are living there. And you enroll in the active aging centre. And I love the active aging component because it's not like all aged care, which has got a particular flavour in this country, where active aging, it's about, right, we can do something. And so that engagement says, right, okay, there's a cafe that you can go to. And in the cafe, they've got a health check machine. And some of you, some of the viewers and listeners may have heard about the Shane Warne health checks at the MCG, at the Gather Round here in Adelaide, at the Adelaide Oval. Some people who go to Priceline might see these health check machines. So it's a very similar thing. It's a machine that you have an account with. It's your data. You create an account and you log into it, and it checks your blood pressure, it checks your pulse, your oxygen saturation, it checks your height and weight, it checks your body composition. It has some questions for you to answer regularly about your mood, how you're feeling, are you okay? It looks at your diabetes risk. So all of these things are automated in this health check machine. And everyone's encouraged to do this because they keep their information and it shows up on their phone, and they can go and see their nurse or the doctor and show what's happening. And then the doctor and nurse can make a decision about what's happening, as opposed to currently in Australia, what happens is, I've got to check everyone's blood pressure, their weight. I've got to check their body composition if I'm lucky. I've got to put something on for an oxygen saturation and temperature. And so it takes a lot of time to do that. And as we mentioned earlier, GPs don't have a lot of time. And so a lot of that stuff doesn't get done in everyday general practice. So the Singaporeans have worked out, right, they can automate all of this collection of clinical information. There's a whole lot of other things as well, like pain scales, quality of life that they're collecting. So the clinician can make a decision with the person about what's actually happening, what the trends are. So it's a much smarter way of actually doing healthcare, where you've engaged the community to actually take responsibility for getting their own numbers to get them looked at, teaching them what to look for and changes and trends. Because I interviewed a whole lot of people in these active aging centres, and they knew, oh, that blood pressure's too high. I'll need to be doing something about that. So I thought, wow, that's really good. Yes, we've got people here in Australia that've got their own home blood pressure machines, but I felt that there was a lot more, understanding that they could be doing things differently. But what was also nice is that socialisation was a really key priority of the Singaporean government for active aging. So there was a national policy on reducing frailty and social isolation, because the link with social isolation and loneliness, we've got an epidemic in this country of this, is that it basically has an impact on your long-term health, increases your risk of dementia and heart attack. So all things that at the other end of the spectrum of when we're getting older, we don't need. So active aging centres are there to reduce social isolation. I saw people, like the men's sheds that were in these centres were next to the health check machines. Who's the hardest group in Australia to get to come for a health check? Men 45 to 65. And so there was this group of 55 to 65-year-old men who were going to the men's shed. They were interacting with other men. They'd have their health checks. They'd have a coffee with them. It was definitely something that a number of them said if it wasn't for this, they wouldn't be getting these checks done. It brought them together. They were working on these benches, making furniture or making things for others in the apartments. And so this is a really useful way of how social prescribing can actually be utilised to improve health. So as I sort of watched this in action, thought we've got lots to learn from a Singaporean government. Their actual health system, when it comes to their GP system and their hospital system, That's still just like many others in the world. So this has only been the last 2.5 years where they've taken this approach to active aging and starting to look at how can we automate the collection of clinical data, because they've worked out they will never have enough clinicians for the aging of their population. They've got 21% of their population over 65 already. So in Australia, we only have 16%, and that's going to be growing. But Singapore is called a super aging nation because it's got to that 21%. The number of working people per senior person over 65 is dropped from 7.5 to around about 2.5 over the last 20 years. So they're really clear. We've got to be smart about how we use our clinicians in order for them to deliver the best care possible. We've got to be smart, they say, how we also empower the community to do more about their own health, because we can't rely on more clinicians suddenly appearing to do it. So these are things that in our country we need to be looking at, taking notice of, and thinking about how can we do this better.
And we definitely need to, because although, yeah, as you said, 4.2 million Australians over the age of 65 currently, 16%, but in less than 20 years, that's going to turn into 6.5 million. So a lot more people over the age of 65. And on the topic of aging, do you see ageism in the medical industry? And, how do you think that is affecting society?
Well, I think ageism is a societal issue, full stop. You only have to look at the social media or the news or a paper to say, right, well, how many really good stories are there about older people? How many great older people role models are there now? They are few and far between, and yet they are an increasing part of our population. So I think that's part of it. I think one of the things from a healthcare perspective, our training for care of older people is poor. That roughly 75% of Australia's GPs and primary care nurses haven't had any formal training in the care of older people. And so that's a real worry when it comes to these numbers you've mentioned and to the growing trajectory of people over the age of 65, that we need the right responses for people's healthcare concerns. So, in the healthcare world, a way of expressing ageism would be, oh, well, you're 80, Nancy. You can't expect that we can do anything for you. You're too old for this and that. So you just have to accept it. That's ageism. As opposed to when I see my people, I go, right, we're not actually going to blame aging or birthdays. We can still build muscle at any age after 65, 85, 105. You can still become more aerobically fit at all those age groups. You can improve your muscle strength. You can actually make change. And so this condition called frailty, which is sometimes seen as a derogatory term for older people, frailty is actually a real condition where we start slowing down, lose muscle mass, we get tired more easily, and we start losing weight unintentionally. And that weight's usually muscle. So frailty then impacts our ability to actually function well, live our lives that we want to. But frailty is not an inevitable part of aging. And this is the really important part, that large parts of the medical world think that frailty is simply linked to aging. And it's not reversible. But that's where we need to actually bust the myths. We need to really say frailty can be reversed. But we've obviously got to identify it early. We've got to, and then you can do something about it. And of course, doing something about it doesn't come in a pill, unfortunately. As most of my patients say, so I say, well, it's not my pill. It's what you do with your life. It's whether you're going to be doing those resistance exercises, building muscle. It's about what changes you decide to make about the food that you're going to eat. It's how, are you going to get out and engage with community? Are you going to join the men's shed? Are you going to get that volunteer job that gets you out interacting with people? Because that's going to be great for your mental health. It's going to be giving you more activity. It's going to give you purpose. These are the things that we need to be doing more of. And they don't come in pills. And they're all the things that the current evidence for healthy aging says we should all be doing more of.
And this is why I started this podcast. It's to get information like this out because people just, there's so much information, but people are not aware, as you said. You know, GPs don't have a lot of time to talk about all of this. So, yeah, I'm so glad that you've brought this up. You spoke about medication and a pill, and earlier you spoke about polypharmacy. Can you just kind of define polypharmacy? What is that? And how can people reduce their medications if they currently are suffering from, an illness?
So, really good question. So, polypharmacy is traditionally defined as taking 5 or more medications, and that's whether it could be prescribed or over the counter, potentially vitamins as well. But theoretically, it's what you get from the pharmacy over the counter or prescribed. So 5 or more per day. And so when we look at the stats on this, roughly 50% of people 75 years and over are on 5 or more per day. So that's a lot of people. So that's the definition of polypharmacy. And then there's super polypharmacy, which is 10 or more. And there's plenty of people are on 15 or more as well. So it's getting more and more as people over 65 are unfortunately collecting more and more long-term health conditions. So they start having blood pressure and diabetes and cholesterol and have a heart attack and they're put on blood thinners. They've got a medication for depression and the list goes on. And more evidence keeps coming up every day for more tablets to be doing more things. So there's our dilemma, is a pill the answer for every problem? And so the answer is if we took more interest in our lifestyle and did more to actually change it, we could reduce some of our medications. So that's one part. But the other part is as we get older, and so let's look at that group 75 plus, our kidney function is reducing, and that impacts how many medications are actually excreted or removed from our body, cleaned out, if you'd like to put it that way. So our liver and our kidney clean out our bodies from medication perspective. So what we've got to look at is making decisions about what's really necessary to take anymore. So a really great example is osteoarthritis of the knee, where many people will take an anti-inflammatory, they'll take some paracetamol, they get prescribed some, say, tramadol, which is a much stronger pain. So they're on, 3 different things for their knee pain. Yet they should have been referred to a physiotherapist and exercise physiologist to build the muscle around the knee in order to improve the function. So that's what's not happening in our system, is that it's too easy to reach for the prescription pad to say, right, for your knee pain, we will do this. And this is, traditionally how we've been taught, have something, fix it, and off you go. Where realistically, in this day and age, we've got to actually sit down, right, let's help you understand how you can actually help your knee, rather than taking more pills, because it's not going to be the answer long term. And so you've got 3 tablets currently when we could be improving the function of your knee and actually reducing the likelihood of you needing a knee replacement if you actually did these things yourself. But coming back to, if trying to motivate someone to go to the gym or do the exercise program or see the physio, there might be financially issues there as well. It's cheaper to actually prescribe the medications. So these are some of the issues that are inherent in our system that then lead to people accumulating more and more medications. But there's plenty of things we can be doing to reduce the medications if, number one, as a GP, I say this is one of my new favorite hobbies, is to actually review people's medication, and to really be clear about which ones are truly harmful as they get older. And there are medications that have what's called anticholinergic side effects, that they dry up our secretions, they constipate us, they change our bladder function, they make our brain all foggy. Many medications have higher impact as people get older. And that then impacts the way they want to live their life. Because if they are actually having more constipated. They've got dry mouths. They drink more fluid. They feel hot all the time. They feel fuzzy in the head. They're going to go and see their doctor, and the doctor treats them with more medications to take away those other things. So it then escalates. More and more things are being prescribed for side effects of other medications. This is really, really common in Australia.
Okay, so let's say our viewers are like, okay, Dr. Chris, you've convinced me. I need to, take more responsibility for my own health. Aside from going to ChatGPT or, one of those AIs, what else can they do?
There's a couple of things. Number one is that yes, you do need a good checkup. So ask for a long appointment to see the doctor. Be really clear. Be armed with a list of these are the things I want a full checkup, and there are under Medicare there are some health assessments where the doctor is paid to do a good checkup, and often people work in teams, a doctor and a nurse, so they are available now. Now, a great thing for women is that there's been a new menopause health check started on the 1st of July, and that means any woman pretty well from early 40s or even younger if you've had a hysterectomy where it may impact the hormonal changes through till the end of life, can have an annual health check. Men aren't quite as lucky to get that yet, but certainly women can actually go, right, I want my menopause health check and I want a full check and I want to look at all the things that I can keep well. So that's often a doctor nurse longer visit. So that's definitely an option. Take your list along, make sure you know your family history as well, because your genetics are incredibly important. They make up 30% of your future risk of illness. But the other interesting thing is that everyone goes, oh, I can't change my genes. No, you can't change it, but you can change how your genes are expressed. It's called epigenetics, how your genes are turned on and off. And that's the choices you make in your life. And that's 40% impact on health. So it's really important not to disregard that. There's 20% of our health is related to our environment, where we work, where we live, all those sort of things. So it's really important. We can change things, but we've also got to be empowered to think about it, as opposed to, in some ways, sometimes medicine can be quite paternalistic, where, you're just told, do this, take this, and there's not a lot of other information provided. So it's really, again, coming back to time, asking the right questions, and this is what we call self-management of ourselves, our ability to care for ourselves, look after ourselves as far as our physical health care and our mental health care, but also our self-management is about saying, if I'm going to see a health professional, what are the right questions I need to ask? Because I've got to educate myself on the things I need to do to keep me well. And that's what a good relationship between a GP and a person can make a big, big difference. If you're just seeing, random people in clinics with no relationship from a GP perspective, if you're just seeing constantly new people all the time from my perspective, or you as a patient are coming in and seeing random GPs, or you never develop a relationship, and it's going to be, right, how do I actually then sit down and have a decent conversation? You've got to actually develop that over time, like any relationship.
Excellent. Okay, great. So wrapping up, where can people find you? Are you online? I will include information in the description below the video, but yeah, where can people find you?
So one of the things, viewers, is that I don't take any new patients. I only work 2 days a week clinically now because the people that I see, they rely on me. And so I'm not going to actually say, right, I'm seeing new people, because then the people that normally need to see me can't see me. So I'm very clear on that. So essentially, but what I do, I do a lot of teaching and training of doctors and nurses around this country. And so primary health networks around the country engage my company, Bollen Health, to actually teach and train and educate and look at new ways of doing things. So we're out there slowly, bit by bit, making changes. And so there is a Bollen Health website that gives you a bit of an idea about what we do and why we do it.
Excellent. And I will include that information. Well, it's been a pleasure having you on the podcast, the first ever. episode. Thank you so much for sharing that knowledge with us. It's invaluable.
Well, thanks for having us, Nancy, and hopefully we've covered a lot of topics in quick time there, and hopefully there is something sensible that people can take away today.
Yeah, I think it was a good session. Thank you.
Okay.